يسعد أوقاتكم جميعا بكل خير. معكم دكتورة نور مرشحة، طبيبة أسنان، خريجة جامعة تشرين 2010 and prosthodontist resident at Riyadh Al University. Today we're going to talk about endodontics or implants, guidelines for single-tooth restorations and full arch reconstructions. Dentists frequently face the difficulty of whether to endodontically treat it and retain a questionable tooth, or to extract it and potentially replace it with a dental implant. Restorability with core build-ups and post-and-core extend of previous restorations as well as the perceived strategic value of a tooth within the dentition. The success rate between root canal treated and implant success rate was similar in Doyle et al. Studies in 2010. He found that the success rate were 94% off for the RCD and 96% off for the ISC at 5 years. Because of similar outcomes, deciding whether to restore a tooth with a root canal therapy or extraction and replacing it with an implant or another type of prosthesis must be based on multiple factors as opposed to treatment success alone. The failure rate for each treatment were consistent at 6%. Complications were found to be 18% for implants with pre-implantitis as the common failure and 4% for endodontically treated teeth with persistent apical periodontitis or retreatment. Comparing endodontic success with implant survival is like comparing apples and oranges. There are also a number of differences between endodontic and implant studies, which may make proposed implant success rates artificially higher. Success criteria for root canal treated RCD teeth and implants. In this systemic review, we can see Iqbal and Kim 2007 observed that much more straightened outcome criteria were normally applied to the assessment of successful RCD, including the absence of periapical radial sensing. On the other hand, the use of less straightened criteria in implant studies, generally simple survival, may translate inherently to higher success rate. This is even more obvious when early implant losses that occur during the initial healing period are not accounted for. According to the recent review, the survival of sound and even compromised and treated teeth that of oral implants provided that implant loss before loading was added to that during function over 10 years. Depending on the factors influencing endodontic and implant treatment outcomes, absence of periapical radiosensing root filling with no voids, root filling extending to 2 mm within the radiographic apex, and satisfactory coronal restorations were found to improve the outcome of primary RCD significantly. Loss of crystal bone also creates aesthetics issues that are difficult to resolve. The location of the abutment interface to the crystal bone, the crown-implant ratio, and the non-axial forces placed on the implant and buccal and bacterial affinity for the implant surface are some of the possible reasons for crystal bone loss. Patients should be informed of the expected loss of crystal bone following implant placement, the potential effect that may have on the prognosis and aesthetics over a long period of time. Significant crystal bone loss can compromise prognosis and lead to failure. Patients should be informed, as I told you before, and the location of the abutment interface to the crystal bone, the crown-implant ratio, and the non-exile forces placed on the implant and bacterial affinity for the implant surface are some of the possible reasons for crystal bone loss. Treatment failure. In root canal studies, failure is typically defined as any sign or symptoms of infection or failure to heal radiographically. A tooth may be fully functional and asymptomatic, but considered failing. In implant studies, implant failure is divided into early failures and late failures. Success and survival rate of RCD teeth. The absence of clinical symptoms and radiograph with an intact periodontal ligament space in the apical region are indications of healing. If the relative sensitivity decreases over time, within 4 to 5 years, the pathosis is also considered to be healing. If a teeth without periapical radiolucency, initial RCD secured a success rate of 97% of after 8 to 10 years, depending on Sjogren et al. 1990. RCD teeth not restored with crowns were extracted at the rate 6 times greater than teeth crowned after root fillings, depending on Calvin 2002. In a study evaluating the reason for failure of RCD, prosthetic reasons, crown fractures, root fractures at the level of post, traumatic fracture dominated and explained almost 60% of the failures. 32% are failed due to periodontal reasons, and pure endodontic failures, vertical root fracture, instrumentation failure, root resorption were rare and accounted for less than 10%. In contrast to root canal treatment, implants are placed into relatively healthy surroundings. Complications and failures occur either prior to implant osseointegrations or after initially successful osseointegrations. And disease manifestation may necessitate several years or even decades of function. Early implant failures occur mainly during the first weeks or month after implant placement and are frequently related to surgical trauma, complicated wound healing, insufficient primary stability, and initial overload. During the first year following implant placement, bone remodeling may cause bone resorption in the marginal area, تقريبا 1.3 to 1.5 mm around implants placed at the bone level. Any further bone loss, particularly reaching more than 2.5 mm, is considered as disease manifestation. Success and survival of dental implants. Patients who had experienced an implant failure had 30% of increased risk of further failures, depending on Pernt 1993. Today, it's evident that the peri-implant tissues are not affected by hypersalivation and or the symptoms of xerostomia. Reduced bone mineral density in osteoporotic patients entails a reduced bone to implant contact but does not appear to inhibit osseointegration. Implant indications have been extended to patients with a history of periodontitis and also to smokers accepting an increased risk for complications and failures. Depending on the factors influencing endodontic and implant treatment outcome, in patients with high caries activity, possibly related to dry mouth as a common side effect of several medications like atropine and appetite suppressants, or associated with syndromes like Sjogren, less effort will be made to maintain a questionable tooth, and implant treatment may be favored. Further, patients with diabetes seems to have somewhat increased likelihood of endodontic complications following non-surgical RCD. Impaired integrity of the patient's non-specific immune system was found to be a significant predictor for negative outcome of initial non-surgical RCD or treatment. Whilst other patient-related factors such as age and smoking and no impact on the healing rates, patients under intravenous biphosphonate medication for more than 2 years and a history of complicated wound healing like falling tooth extraction are not a candidate for implant treatment due to the risk of biphosphonate-induced osteonecrosis. Aspects related to the longevity of root canal treated teeth and implants. Good long-term prognosis and greater flexibility in clinical management indicates that RCD and even treatment should be performed first in most instances unless the tooth is judged to be untreatable. Most implant failures are directly related to the implant itself. But for endodontic failures, the reason to non-endodontic factors, yani an RCD teeth survive better if probably restored with single crowns being more favorable than if DBs. But for the failures related to the endodontic, they frequently be resolved by any type of retreatments. If the degree of difficulty of the planned therapy is assessed, it seems that any type of endodontic or periodontal treatment is less time-consuming, less expensive, and easier to perform in anterior teeth than in multi-rooted premolars and molars. After RCD in the anterior region, grayness, of the clinical crown possibly impairs the aesthetic outcome and indicates bleaching and or crown restorations. In implant treatment, the clinical crown can be designed so as to ideally mimic the systemic situation on the contralateral side, provided that the implant position is appropriate. The aesthetic outcomes is, however, often compromised due to soft tissue recession from unpredictable healing following tooth extraction and implant surgery. Posterior teeth with questionable prognosis, however, are placed by an implant with less restraint than in the aesthetic zones for the anterior, where concerns about the risk of gingival recessions and possible lack of interproximal mucosal tissues are of greater importance. So great efforts should be made to save a questionable anterior tooth in order to ensure preservation of the soft tissue architecture. For the oral situation, the situation of the adjacent teeth and the entire remaining dentition is included in the treatment planning, considering the following factors: overall arch condition, condition of teeth adjacent to the questionable tooth position, strategic tooth, number of missing and present teeth for FDPs. Patient-related factors, expectations, aesthetic treatment duration, medical condition, financial situation. As a conclusion, the long-term success rates is not enough to make the decision. For single tooth restorations, an increased risk in restoring a tooth with a questionable prognosis is acceptable in particular case. In case of full mouth rehabilitation, single tooth prognosis and the site-specific treatment recommendation is possibly overloaded by the overall treatment planning and a therapy-related decision for a strategic extraction may be required to perform reasonable reconstructions with uncompromised long-term prognosis. Irrespective of the type of the selected treatment option, ongoing maintenance is required in order to reduce the risk of compromising the longevity of the reconstructions. And thank you.